MRSA, methicillin-resistant Staphylococcus aureus, the gram-positive staphylococci. So MRSA colonization. 2 to 7% of adults are MRSA colonized on the skin. 4 to 15% of healthcare workers are MRSA colonized. So going on the surgery will increase the risk of person getting the MRSA infection, and there are some concerns that many antibiotics do not treat MRSA, but that are used inappropriately. We'll look at the MRSA treating drugs, Vancomycin IV, Clindamycin or Lincomycin, Trimethoprim plus sulfamethoxazole, known as Bactrim or Cotrimoxazole, doxycycline, and rifampicin. Let's check out the Vancomycin intravenously. This is the antibiotic flower. Vancomycin 1 gram twice a day for 60 kg adult. The advantage is that it is first line to treat MRSA and it is commonly used. Preferred treatment for patients with Staphylococcus cellulitis with systemic features of infection such as fever. It is not actually causing nephrotoxicity, and dose calculation differs from different weight, so it is more precise. The disadvantages of vancomycin is that it is very large molecule, like 1,500 gram per mole. It cannot be absorbed by GI tract, and it cannot cross the blood-brain barrier, so it is useless when treating meningitis, so it is not used. So it is usually given IV because of the large molecule. For the few cases, it shows a local effect on GI tract, so it is effective at treating local infections such as C. diff infection. So Clostridium difficile infection, the most severe diarrhea causing one. So it is just for the local use, not for the general use. Here we have a loading dose. The loading dose is the one that achieves therapeutic concentration more quickly. So this is for the really sick patients, such as the patients who got the serious infection like sepsis. So time to reach the steady state is the same, but the steady state depends on the patient's own body, not the drug itself. But the time to reach the therapeutic state is faster, as you can see in the picture. Let's look at the clindamycin. This is clindamycin. We give it either IV or orally. It is time-dependent antibiotic, suitable alternative of vancomycin. It is more potent than lincomycin. Both clindamycin and lincomycin are in the same group. It is first line for MRSA cellulitis, safe for pregnancy and breastfeeding. It has risk of Clostridium difficile disease, and because of this has cross-reactivity. If the one has the allergy in clindamycin, then he or she cannot use it in the lincomycin. Lincomycin. It is second line for MRSA cellulitis. It is not that potent and it is weaker than clindamycin. It is safe for pregnancy and breastfeeding, and as I said, it has the cross-reactivity. Let's check out the Cotrimoxazole, as known as Bactrim. We can see it has a broad spectrum. Trimethoprim 160 mg plus sulfamethoxazole 800 mg. Cotrimoxazole, also known as Bactrim. It treats MRSA, but you should avoid the sun exposure and wear protective clothing when going into the hot sun area because it has sun exposure allergy. Yeah, Bactrim is used for mild to moderate infection and should avoid using it in the first trimester for pregnancy. And sulfamethoxazole has a cross-reactivity with dapsone and it is contraindicated in the late pregnancy. There is a risk of baby hemolytic anemia and jaundice. When using Bactrim, you should monitor the blood count and the folate status, monitor the renal function, and obtain urine analysis every month.